Hello, this is Dr. Carol Murphy again, presenting this time the lecture on atypical neurodevelopment for PS253 lifespan developmental psychology. So, atypical neurodevelopment basically means not typical development. And there are numerous genetic and environmental variables that can result in atypical development. For one thing, the prenatal period of development is really vulnerable to insult or injury, and this can be critically detrimental to the healthy development of the fetus. Now, unfortunately, when we say that this is a critical period, it means that if things don't go as they should go, if everything is typical in terms of development, then the damage to the fetus is not something that can be repaired, and that's why it's called a critical period. There are some sensitive periods that we talked about regarding speech and language. It's thought that the early years are a sensitive period, and it's important to teach language in those early years because it doesn't seem to be so easy to teach later than that if the individual hasn't acquired language in early years. But it's not as clear cut as it is regarding insult or injury to the fetus in the womb. In other words, it's not impossible totally. There is no record to indicate that it's totally impossible that an individual past the early years would learn to speak. It just seems to be more difficult. But in the case of the fetus in the womb, if there's damage done, we say it's critical because it cannot be repaired. So that is a critical period of development. Now, many things can cause atypical development, and we can't go into them all because there simply wouldn't be time. But we will go into the disorder called autism spectrum disorder. The reason being that it has become very prevalent in recent times. And that's why it's received much attention. So it's not clear what the cause of the increase in autism spectrum disorder, or ASD, it's not clear what has caused such an increase. It may be due to greater diagnostic expertise. In other words, it could have been present in previous years, but not recognized. Other factors that could be relevant, though, are genetics. There's certainly a biological aspect because there's a ratio of 4:1 male to female respectively, and there's a higher incidence in twins. It's possibly related to the older onset of the first pregnancy. We know that biologically, we have probably the best chance of everything going very well at a younger age. However, psychologically, older mothers are well equipped to deal with newborn babies. Very young women are not as well equipped psychologically to deal with all that goes with pregnancy and child rearing. Okay, so this is a graph of the prevalence. This is from Autism Speaks. So you can see that in 1975, 1 in 5,000, 1985, 1 in 2,500, so there was double the cases. In 1995, 1 in 500, then 1 in 250 in 2001. And we'll just go right up to 2009, 1 in 110, and it's been reported in some places as many as 1 in 60 in the States. Now, there was previously an emphasis on distinct categories in ASD, and the DSM-5 has basically obliterated those categories and just used the one term, autism, but described it as a spectrum disorder. So sometimes the ASD would, this disorder, sorry, sometimes the disorder was given the name of Asperger's syndrome. That was usually applied when the individual had high functioning autism. In other words, was probably good academically and could speak and so on, but had the classical deficits in social skills. Rett syndrome was another type of diagnosis given in some cases in autism. Childhood disintegrative disorder also, and PDD, in other words, pervasive developmental disorder, not otherwise specified. A complicated way of saying it, I think. Anyway, now there's just one diagnosis, and it's ASD. But there is a very wide range of severity. And in other words, you can have one individual who may be have very severe autism and not have any speech, not appear to understand. In other words, if cannot follow directions or doesn't seem to recognize the meaning of language, maybe has a lot of stereotypical behaviors. And then on the other end of the spectrum, you can have somebody such as Temple Grandin. I don't know if you know her, but she's an individual, a lady with autism, and she was quite famous in that a film even was made about her. Temple, you can see her online, and I have a video. I might put it up, but I don't use it as much for this class as for the applied behaviour analysis class. But it's quite interesting, and she describes how her thinking was so very different. She became a scientist nonetheless, and I think that's a good indication of sort of what the individual brings as well, because even although she is still, has the ASD, she has managed her life quite well, and as a very interesting person. So she kind of created a niche for herself, created an environment in which she could be successful. She takes care of animals, when they're going to the slaughter. She's quite fond of animals, very attached to them. She said she always related better to animals than to humans. So she designed a system in which the cattle would be at least brought to the slaughter by a means that was that they were amenable to, and so there wouldn't need to be any sort of cruelty involved. That was the way she saw it. Anyway, getting back to the general population with ASD, as I said, it can range from mild to moderate to severe. So the DSM has always listed a triad of impairments as criteria for autism, so that there would be a deficit in social interactions, communication deficits as well, whether they were not verbal or non-verbal. Restricted patterns of behavior or stereotype behavior. Restricted patterns means there can be restricted interests, and an individual with autism may be able to speak, but is actually speaking only on one topic really, and doesn't respond very much to other topics. So those are the characteristics. Individuals who don't speak may have habits that seem strange to the rest of us, possibly just tapping on a table for several minutes or hours, or staring at lights, which is like self-stimulation in that way. So the behaviours then of children with ASD are a little different than the rest of us. So they show persistent deficits in social communication and social interaction. Deficits also in social, emotional reciprocity. In other words, they may not respond to hugs or greetings. Deficits in non-verbal communicative behaviour. They may not make eye contact. And deficits in forming relationships appropriate to that developmental level that they're at. Frequently, there are speech deficits. And as I said, child may not be able to speak at all, or may only speak language that's intelligible to their immediate family, but nobody else can understand it, or may only emit echoic speech, which is the repetition of phrases and so on, or the repetition of words. There may be no attempt to communicate through signing or other body language or facial expression. For example, children who are born without hearing will always begin to sign. If they're otherwise typically developing, they will, even without formal teaching of sign language, they will invent with their carers a sign language at home, whereas these children don't. If they're not able to speak, they don't do sign independently. It has to be taught. And they very often wouldn't understand facial expression and don't understand the emotions of others. For example, a typically developing child will respond if an adult is angry. They may respond with fear. A child with ASD may or may not. Some may get it, some may just not understand that somebody else being angry may present a threat. That just maybe don't get that. So the deficits are very specific to ASD. For example, children with Down syndrome, although their intelligence is affected by the disorder, their emotional intelligence is not affected, and they're very well able to communicate and don't have any of these sort of deficits, social deficits that are seen with children with ASD. There are also other characteristics. So there may, as I've said before, there may be stereotyped or repetitive speech or motor movements or use of objects. There's often an excessive adherence to routine, a strong resistance to change, and as I said, sometimes highly fixated interests. At a lower level, you might have a child who is entranced with the doors of a lift opening and closing, and at the higher level, then you may have an individual high functioning with ASD who's maybe highly interested in the construction of ships or boats, but will not really engage with people about anything else, and will not really understand that other people are not so interested in that area. There's also characteristic problematic reactivity to sensory input or unusual sensory interests, such as staring at the lights, as I've described. But the reactivity is sometimes seen, not in every case, but sometimes seen where the child is highly sensitive to sound and will cover the ears if the sound is in any way loud, and may get upset. And another sensitivity is sometimes water on the skin. The child may react very dramatically to any wet getting on the, say, for example, the sleeve of the jumper that they're wearing. Other sensitivities are that they may not be able to wear certain fabrics. They may be reactive to that. That's just a photo of the boy. He's very fixated, as you can see, on the holes in the bar. And what else can look like ASD? Well, attention deficit hyperactivity disorder and anxiety can look like ASD. Obsessive compulsive disorder has similar characteristics, some similar characteristics, but certainly not all. Anxiety and language delay can look like ASD, but it's not necessarily, because sometimes there's a specific speech deficit, and that may be causing the anxiety as well. And cognitive delay plus anxiety might be looking like ASD, but not necessarily is ASD. So the epidemiology then, traditionally it's a rare disorder, as I said, occurring in 4 or 5 per 10,000. The ratio of males to females remains unchanged. Recent studies show that 1% of all 8-year-olds have ASD. Now that's quite high, that's 1 in 100. These data are taken from the Centre for Disease Control in the States, and they estimate then in 2013 that there was 1 in 68, so that's higher again. We don't have data for rates in Ireland, but the HSE has reported a 40% increase in the rates of intellectual disability in recent years, and it seems likely that that would include children with ASD, and that's maybe causing the rise in the recorded amounts here. This is just a graph of the changes in the recorded data indicating children at 8 years of age, and the difference between 2002 and 2006, you can see there plainly a very high increase. The etiology is unclear. Was initially described as an emotional disorder related to parenting, and now it's very recently diagnosed disorder, actually only discovered in 1943. That may not seem that recent to you, but in medical terms, that's quite recent. If you consider that bipolar disorder, for example, has been recorded for centuries. It's been recognized, it's been described in detail. Now, given that autism is such a distinctive disorder, once it's anyway severe, the characteristics, as I say, are quite distinctive and quite different from other neurodevelopmental disorders, such as Down syndrome, or that it is surprising that it was only first recorded as late as 1943. So, as I said, it was initially, that was Leo Kanner who discovered or identified autism, and he described the children as sort of locked into themselves. They seemed to be detached from their environment. And as the disorder presented a lot, or seemed to present a lot, in the middle class population, it was thought that it was related to working mothers, because a lot of the upper middle class women worked, and these mothers were blamed actually for the disorders of the children. So it was really a horrible situation for them to find themselves in, that not only did they have the difficulty of raising a child with autism and, very little effective treatment in those early days, but also to have it put about that, it's basically that these mothers are so cold. They were called refrigerator mothers because they were working. They were meant to be so cold that the child basically turned into himself or herself, because they were getting no interaction from the parent, that they cut off from the world because they were so emotionally detached. And this caused a lot of hurt for parents who already had problems to deal with. And it's a very negative approach also, in terms of, if you think that you're going to be blamed for your child's disorder, it really adds to the problem, because people very often are reluctant to go to have a child diagnosed, because it's hard to face up to such a thing. It's for the parent, it can be devastating. So there's that reluctance, maybe. Maybe there's the hope that things will all yet be well, and maybe it's nothing, and so on. But if you think you're going to be blamed as well, then you're much more likely to put off going for a diagnosis. Now, there was a Dr. Bettelheim who put forward that notion of refrigerated mothers, but in his latter years, he actually retracted that and apologised for the hurt that he had caused. Dr. Bettelheim ran a facility and tried to give the children unconditional love, and that if they were basically sort of pandered to from morning till evening and cuddled, whether they sort of wanted it or not, that he could cure them. But it didn't. There were a lot of problems with Dr. Bettelheim's approach. Anyway, what he said about parents did not prove true or valid. Research has not shown that mothers of children with autism have any distinct coldness or other distinct features compared with parents of typical typically developing children. So it could be a gene, environment, interaction, and it may negatively impact learning. The immune system also seems to be impacted with ASD in several children, and also the gastrointestinal tract. So some of the children will have digestive problems and bowel problems. So it's not clear at this point why those characteristics are shown in some children with ASD and not in others. So the genetics are complex. They're always complex to understand, but the strong indication that genetics are involved in it are, firstly, as I said earlier, the prevalence of autism in boys compared to girls. However, although that's definitely a factor, it does indicate biological impact. I should also remind you that in a lot of illness and disorder, the ratio of males is higher than females. That's just part of the biology. The strongest evidence, though, for genetic influence comes from the twin studies. So 60% of monozygotic twins are concordant for the full syndrome. Now, monozygotic twins are basically identical twins where the egg, the ovum has split. It was originally one egg and then it's divided into two. So that's the concordance is where that both twins have full syndrome. 90% concordance for related social or cognitive difficulties. So that's very high concordance. So in other words, if one twin has it, both twins have it. Also, the risk for siblings of a child with autism is high, it's 5%. And there are some data also to indicate that there's a higher rate of ASD among twins. So those things would point to the influence of so diagnosing ASD may involve direct observation, interactions, or clinical probes. So pointing and directing the child to look at the age of 12 to 15 months, calling the child's name, say age 12 months, asking where's mommy, checking eye contact and gaze referencing, pointing, evidence of joint attention. In other words, does the child look towards the parent in uncertain situations? Also, the repetitive movements and sensitivities would be something to look for. This is from the Academy of Pediatrics. Probing the questions for parents would be maybe, what's your child's favourite toy or type of play? Does your child babble? Does it wave bye-bye? Does he raise arms to be lifted? Does he hear your voice as well as other things in the environment? And that would be about the child, let's say, 9 to 12 months. Does your child have pop-up words? You know, has he or she started to say the odd word? So that's, you may think very early to be looking at children for signs of ASD. But as I said before, the earlier treatment, the better the outcome. Screening tools are also used. So there's the checklist for autism in toddlers, and that's called CHAT. And then there's the MCHAT, which is a modified checklist And then there's the pervasive developmental disorder screening test. So that one has one of the older names, but it's still sometimes used. There's no recommendation for screening school-age children, but you could consider the social communication questionnaire could be useful. With the MChat involves 23 yes or no questions. It measures social reciprocity, language, and some motor behaviours. From 18 months to 20, it can be used with children from 18 months to 4 years of age, detects ASD or language impairment, mental retardation. There's also the adaptive skills test, the Vineland Adaptive Behaviour Schedule, version 2. So diagnosis then involves a comprehensive multidisciplinary evaluation. The Autism Treatment Network protocol would recommend medical evaluation, psychological evaluation, the Autism Diagnostic Observation Schedule, which is another questionnaire, other autism-specific diagnostic tools, and screening for common related medical issues. For example, there are often sleep problems involved with children with ASD, and as I said before, gastrointestinal problems. So these are all based on the DSM-IV criteria, the triad of impairment. The treatment then, getting started, would be early intensive behavioural intervention. So this early intervention ideally would take place preschool stage or even earlier, and school age certainly. It usually involves speech or language therapy, and the ABA programs, the early intensive behavioural interventions generally involve, sometimes they'll have an ABA tutor and a speech and language therapist. The speech and language therapist can point to specific deficits, and the ABA behaviour analyst will be guided then into which language behaviours might be the focus of their intervention in teaching the child to speak. There's also, for children who don't have a verbal repertoire, the system of picture exchange communication can be useful, where the child presents the picture of what it is he or she wants instead of pointing maybe. There's occupational therapy also sometimes involved. So sometimes sort of building the tone of muscles and that, and sensory integration therapy. I don't pretend to know all of the details of what the occupational therapist, of the type of therapy that they use, but certainly they're often involved. They might, for example, have the child exercising the fingers, or maybe trying to coordinate hand and eye movements, that sort of thing. Okay, so can psychology help? Behavioral psychology has been very successfully utilised in the area of atypical neurodevelopment and improving outcomes. It is the only proven therapy with decades of scientific research to support it. Other interventions used for ASD might be medical interventions, and they can sometimes be useful for a child or an adult who's maybe severely self-injuring or endangering others. So sometimes medication can be useful in reducing that type of aggression Unfortunately, though, it has negative side effects because it sort of can sedate the individual to some degree as well. And of course, it has other biological side effects that are negative. And since that, if it's effective, is only effective for the term that it's used, and as soon as you stop the medication, the difficulties return, that's another negative aspect. There are some negative aspects to behavioural treatments also, in that they entail a lot of resources, a lot of training and expertise and tutoring. However, they are quite effective and in the long run tend to cost less because they can bring about successful learning for so many of the children who receive early intervention. See the Larson papers 2013 and 14. Thank you.